Advances in spinal cord stimulation. So this is a very brief lecture that is just high-level targeting a description of kind of the evolution of what has occurred over in 15 minutes, the last 35 years of spinal cord stimulation. So our objectives are, as I said, an overview of the history and just trends in this therapy. So this image is just a quick little kind of glance at the dates over which spinal cord stimulation has been part of pain management. Our first spinal cord stimulation device was tested in humans in the 1960s. Remarkably, I wouldn't have wanted to been that patient. The initial studies and experiments on this therapy were percutaneous leads, but then ultimately the first versions of this therapeutically were paddles. It was first implanted in 1981. Again, wouldn't want to have been that patient. And then soon thereafter, there was sort of a cascade of advances, and the trends of which we'll go over in the next several minutes. This is another way to look at it. Similarly, what you see is that it was 1970s when these studies were first occurring. I think it was 1979 when it was FDA approved for therapeutic use. You can see the array of paddles right here, which were the first versions of spinal cord stimulation to become used in therapeutics. And then over the years that followed, there have been trends in first advances in the paddle design, and then in MRI compatibility, implanting these devices, making them rechargeable. And then in the past 10 years, there has been a deluge of advances and research in the various different programming capabilities. So lead design was the first target for researchers, moving from monopolar to bipolar, meaning that the stimulation no longer moved from using one electrode on a lead and another electrode on the same lead, and then using one electrode on one lead and then another electrode on a different lead. So your cathode and your anode were on the lead itself. Then we started the multi-electrode arrays, where you would have, like I said, 2 electrodes on a single lead, and that could be either on a percutaneous cylindrical lead or it may be on a paddle. Tripolar guarding and anode-cathode montages using the battery as what you hear a can, so that it could be also treated as a cathode, has been an advance that has occurred in that early stages of the evolution of spinal cord stimulation. Another thing that began to be discussed is the spacing of the contacts and the number of the contacts. So even today, when you look at the various spinal cord stimulator leads, you'll notice some of them are widely spaced. As an example, Nevro's lead spaces are very wide in comparison to Boston Scientific. And then there's also a lot of variation in the number of leads, ranging from 4 was how this first was the advent of spinal cord stimulation. Now the only lead with 4 on it is a DRG. But you can also have electrodes that have up to 16 contacts, which would span more than 2 vertebral bodies length, and that is the Boston Scientific design. Multiple independent current control is a mouthful, but what that means is that earlier in this technology, each of those leads that I'm referring to, in most situations, each of those contacts, most situations there's 8 contacts, they were either on or off. You had an anode and a cathode, and it was 0 or 100% coming from that contact. And it was Boston Scientific and Nevro as well that then subsequently had a focus on having multiple independent current control, where you could have any one of those given contacts be titrated up in its contribution to the stimulation in a percentage basis. And you could have multiple on any lead. So you could have a single lead that has 5 electrodes that are contributing to a stimulation waveform, some of them at varying different proportional contributions. The next thing that occurred was compatibility with an MRI machine. There's at least one gentleman in the room who's a radiologist for whom this is a passion. It's a passion for anybody who has these devices, because the longer you're in this field, you will all experience situations where patients come to you urgently needing to have them removed so they can have an MRI. So MRI compatibility should be at the top of all of our attention. And was first approved in 2016, and then their first rechargeable cell was in 2004. Programming advances is probably what your brains are swimming with right now, especially if anybody dares to attend NANS. It is very confusing and convoluted. The sequence of these could be debatable, but as a general theme, this is kind of the advent of each of these different advances. The first was sensor-driven feedback forward. So this is, I believe it was Medtronic that had a sensor within the lead, so that we know that the epidural space can vary in size, right, according to its capacity, or is varying according to your position, being erect or supine, as well as according to the level in the spine that the lead is implanted. And so I believe it was Medtronic that had the first lead programming mechanisms that accounted for this. The programmer would enter the data in terms of what level the lead is placed at, or what level the contacts that are being utilized is at. And then that would be a contribution to the programming algorithm. And then also the lead could sense a change in position and adjust the amplitude of the energy according to that. High frequency is represented in this slide here. High frequency stimulation blew up neuromodulation about 10 years ago. The company Nevro was the first, of course, to release this, and it absolutely changed the face of neuromodulation. High frequency is 10,000 hertz. It's huge, right? You heard us talking, or me talking recently about 50 for a DRG. Can you imagine, right? This is enormous. And there's a lot that comes with this. This is far beyond the capacity of us to sense. If you imagine, when we talk about frequency, we're talking about, waves of energy. And when I speak with my patient about this, I make an analogy to a dog whistle, where dogs are able to sense a different frequency than the human ear. And similarly, the frequency of neuromodulation can be very impactful, but is at a frequency that our nervous system is unable to perceive, like the high pitch of a dog whistle. There's a lot of nuances with this, however. One of the things that was appreciated about this was that it was new, it was novel. The concept was that this type of frequency didn't stimulate the dorsal column, but the dorsal horn, which was really different. It was nice because it was not patient specific. It made for a lot of ease with procedures. The leads were placed like a recipe, spanning and overlapping in a staggered form, the T910 disc space, regardless of what your patient's pain pattern was, as long as it was, waist and below. It was the same procedure every time. It's a lot of energy, and so it required a new concept in thinking about energy efficiency, charge burden. A patient who has a Nevro system needs to charge that IPG every 1 or 2 days and sit still and add that to their schedule. It also chews through that battery a lot faster, so these are needing to be replaced more frequently. That was a new concept, and out of this, there was a discussion in the neuromodulation forums around the idea of neural dose and charge burden. Those are totally new ideas that came out of this really important and revolutionary step forward. Also, you see the term there, wash-in, because Nevro devices, there's something unique to this type of stimulation, which requires a period of time, several days. They say they will advise you like 3 to 5 days of sort of a silence in pain relief, no change, until something occurs. So that required a different kind of orientation when you were performing a trial, because patients are typically undergoing a 7-day trial, and if they're not getting pain relief, there's a lot of wait for it, and then maybe around 5 days, it starts to arrive. It can be a little confusing. So BURST, DR is for de Ritter. That's the name of the researcher who led this charge. There are a lot of articles on this. The Sunburst trial is kind of considered the landmark study for burst stimulation. This is a study that was, it was a study in which the patients were randomized after implantation. So there was no trial specifically with burst. They had a conventional stimulator trial, and then after implantation, a group of them had burst DR, a group of them had conventional stimulation, and the outcome was that subjects preferred burst. That was their positive outcome. The burst stimulation is also subthreshold. It is at a high frequency to deliver a subthreshold. It is a unique proprietary stimulation design that has pulsed packets of stimulation in this high frequency. I think it's 5 or 7. It's these little pulsed packets, and then there's an interphase delay between those pulses, and then there's an active recharge period. And the reason that this was designed so was because it was thought to resemble normal function, normal firing of a dorsal root and of the nerve within the nervous system. DTM is a newer term, diffuse target multiplexed spinal cord stimulation. It's a big old mouthful. This study, the DTM is performed by Medtronic devices. And the idea with DTM, there's a similarity here that you'll see. The DTM, similar to DRG, has a attention to pointing out that its data suggests that there is a behavioral or a mood benefit to this stimulation, to these paradigms. They've demonstrated improvements in pain-related and mood behaviors among patients that receive this type of stimulation. They have also drawn and connected the dots between an idea that this particular pattern of stimulation has effect on glial cells in the dorsal column. And glial cells are glial cells make up like greater than 70% of the actual substance of neural tissue in the central nervous system. I have a suspicion that most spinal cord stimulation has an effect on the glial cells to some measure, but that was the reason, that was kind of the concept of this particular algorithm of stimulation that they felt advanced it beyond or made it different than others. Closed loop stimulation is kind of the next wave and a big topic right now. What I've talked with you about so far, for the most part, is unidirectional information. The programmer sits with a patient, programs something that is delivered to the patient, but that there's nothing that is received back from the patient to instruct any changes in that neuromodulation. And aside from, you could maybe, suggest that the position sensory is a type of closed loop, but really this is different than that. This is evoked potentials. These evoked compound action potentials are a measure of the sum of action potentials from multiple nerve fibers in a location of the central nervous system. And what this closed loop evoke study discusses is a spinal cord stimulation delivery system in which it's also able to sense those evoked potentials coming back, echoed back to the lead from the nervous system. And then that can be used to adjust the amplitude of the spinal cord stimulation that's being delivered. So in a sense, this is really also about neural dose, because what we're doing is adjusting the amplitude of the energy that's being delivered to the nervous system in response to how much of these ECAPs are being activated and communicated back to the lead as being activated. So closed loop is exciting because it's the first time that we've had any concept of a bidirectional relationship with neuromodulation, which seems super attractive and natural to move in that direction. There's been a lot of discussion. Doug certainly he knows a great deal about this and would be an interesting person to speak with this weekend. There's a lot of discussion about whether the ECAP is the right biomarker or not, because this biomarker is telling us about how much penetration of the energy is reaching the spinal cord, and that instructs us on neural dose. But then what do we do with that, right? If we have a system that reduces neural dose, that means that the patient has a little bit longer battery life or has more charge time between their battery recharges. Is that a meaningful outcome? Maybe it is just the first chapter in a new way to look at neuromodulation that is examining what biomarkers would be valuable for us to receive. Maybe it's neurotransmitters, maybe it's something different. So the last here is FAST. It's fast-acting subthreshold surround inhibition. This type of stimulation is subthreshold. It does stimulate the dorsal column, not the dorsal horn. Remember, high-frequency Nevro-type subthreshold, high-frequency stimulation stimulated the dorsal horn. This is stimulating the dorsal column. It also is unique because it is extremely fast. In small studies, the studies that have been shared this response have been in the neighborhood of 20 or 30 patients. But what patients are reporting is that from the time that it's turned on, they notice a meaningful reduction in their pain within 12 minutes. Super fast. For a subthreshold program, which our other most notable model is Nevro's, which takes days. The reason that they believe this happens is because the stimulation is not targeting the central point of stimulation. When we map the nervous system, you see your representatives doing this. They're trying to identify which exact location within the nervous system produces stimulation that overlaps a patient's area of pain. When they do find that, they don't actually stimulate that central port of stimulation. They stimulate an area around it and try to inhibit stimulation or shield stimulation from that central point. And the concept is that this is probably avoids an experience of overstimulation that can be problematic for some patients. So the last thing that we're seeing now is expansion in indications. For so long, our indications have been lumbar post-laminectomy, failed back surgery. Now, chronic radicular pain. If you have an extremely generous insurance company policy, you might get pain syndrome, which for chronic pain syndrome, for whatever that means. There's an expansion now in identifying other indications for which there is substantial evidence to include in consideration for this therapy. Diabetic peripheral neuropathy was the most recent. This was another great thanks to Nevro for doing this. They've really been leading the charge in many ways. And then, of course, it took a great deal of intention and effort and money to get that overturned, and then other companies, followed in their heels. Probably they all have some benefit for diabetic peripheral neuropathy, but you have to appreciate that kind of effort in a company to change policy this way. Non-surgical axial low back pain is something that's recently been approved as well, which is surprising in my opinion, because we've always thought about neuromodulation as being something for the treatment of specifically like neuropathic or radicular pain, and this is specifically saying contrary to that. And then at this time, there are active studies, perhaps even in publication right now on chronic cervical radicular pain. Cervical spinal cord stimulation has been very popular, very common, and also very off-label for a really long time. And that will be changing in the very near future. And another big surprise is spinal stenosis, lumbar spinal stenosis with neurogenic claudication. That has been an area where, there's varying opinions here, but I would say most people have considered neurogenic claudication, something you couldn't reliably advise your patient would improve with neuromodulation. And there's some energy and some intention right now to look at that closer and perhaps be able to achieve authorization for this as well. Questions?